Today we're going to be talking about an update on adult immunizations. The objectives are listed on your slides here. The first is we will outline the ACIP recommendations for routine adult immunizations. We will also review the illnesses that the immunizations aim to prevent. We'll identify the indications and contraindications of each vaccine, and we'll describe common misconceptions about these vaccinations. I'd first like to start out with just a little bit about vaccination history. At one time, infectious diseases were the leading causes of death. Even up until 100 years ago, infectious diseases were still leading causes of death in this country. In the 1790s, Edward Jenner's cowpox experiment really led to the first vaccination. He observed that milkmaids who were infected with cowpox did not get the smallpox disease. So based on this observation, he did an experiment with an 8-year-old boy. He inoculated him with some of the pus from a cowpox lesion. And then he exposed the boy to smallpox, and the boy was not infected with the smallpox illness. And so that's really where the first vaccine came from. Even in the early 1800s, the first smallpox vaccination use was widespread. However, it did not take long for the anti-vaccination movement to come. And we see that anti-vaccination movement still today. But so even with the first vaccine, the anti-vaccination movement was not far behind. Although the smallpox vaccine was in the 1800s, most of our vaccines have been developed in the 20th century. The adult immunization schedule, the most recent one from 2013, you can see here on this slide. These are updated every year. They are approved by the ACIP, or the Advisory Committee on Immunization Practices. They are also approved by the American Academy of Physicians, the American Academy of Family Physicians, the American College of Obstetricians and Gynecologists, and the American College of Nurse Midwives. They can be found at these websites. The 2014 schedule should be coming out shortly. Immunization rates right now are at an all-time high for infants and young children. We are really, really good at vaccinating this age group. However, we are unacceptably low in our vaccination rates for adults. We have seen some increase in the tetanus, diphtheria, pertussis vaccination rates in adults. That really can be attributed to a couple things. We have really pushed advertising about the importance of getting that booster. We are vaccinating on the labor and delivery floors of grandparents who come in to see newborns. Some hospitals are doing that. They'll update their Tdap vaccine at that time. We are vaccinating pregnant women with each pregnancy with the Tdap vaccine. So in those instances, we're getting ahead with the Tdap vaccine, but the other immunizations of adults we're not doing a very good job of. And we see that because adults are still suffering from vaccine preventable diseases. So we're going to talk first about the tetanus, diphtheria, and pertussis illnesses and the vaccine. Tetanus was first described by Hippocrates in the 5th century BC. Wasn't until 1884 that we actually discovered the etiology of tetanus. And we started with passive immunization in World War I, and then the first inactivated tetanus toxin was really first widely used during World War II. Tetanus is caused by Clostridium tetani. This is an anaerobic gram-positive organism. It forms spores, and the spores are found in soil, animal feces, and also contaminated heroin. These spores are very, very resistant. They are resistant to antiseptics. They are resistant to heat. They can actually survive autoclaving at 250 degrees Fahrenheit for 15 minutes. You do that and these spores will still survive. So that gives you an idea of how strong and resilient these spores are. The clinical features of tetanus are as follows. The incubation period is about 8 days. It can range from 3 to 21 days. There are 3 forms of tetanus: local, which is uncommon, cephalic, which is really rare, and generalized, which is the most common form. Generalized tetanus causes descending trismus or lockjaw, difficulty swallowing, muscle rigidity, and spasm. And I'll show you a picture of what that looks like here in the upcoming slide. Neonatal tetanus is a phenomenon in and of itself, and this occurs when an infant is born without immunity. Usually this is because mom is not immune, and then the child is infected because of the umbilical stump being cut with an unclean instrument. And so then the baby forms neonatal tetanus and ultimately dies from that. So this is a picture of what the rigidity of tetanus looks like and what it causes. And this starts in the jaw and then works its way down. And you can see that it's worked down through the neck, through the back, even into the hands of this patient. Diphtheria is caused by Cornicobacter diphtheriae. There are 2 types, respiratory and cutaneous. The symptoms don't occur until about 2 to 5 days after being infected. 5 to 10% of all respiratory cases are fatal, and up to 20% fatality can occur in children under the age of 5. So for the respiratory diphtheria, typically patients have a sore throat. This is because it affects the pharynx and the tonsils. They have a fever, but it's not high, and they don't really appear that toxic, not that sick. What you'll see is a gray membrane covering the tonsils and the pharynx and even into the nasal passages. Cutaneous diphtheria causes a scaling rash, some sores or blisters. It's painful, it's edematous and erythematous in that region. It's caused by poor hygiene and crowded living conditions. So you see this in, for example, a homeless population. This is a picture of the gray membrane that we described in the respiratory diphtheria. So you see that covering the tonsils. So imagine that on the tonsils, the pharynx, and in the nasal membranes. Pertussis once was a major cause of childhood mortality. In the 1940s, there were over 200 cases reported every year. Since we have introduced the vaccine, there has been an 80% decrease in the incidence of pertussis. However, since the 1980s, we've been seeing an increase again in cases. And so that is why we're having the campaign to revaccinate or to boost our adult population. Pertussis is caused by Bordetella pertussis. It is a gram-negative bacteria that attaches to the cilia in the respiratory tract. It causes inflammation and swelling then in the respiratory tract. It produces toxins, paralyzing the cilia, and that way patients can't clear the pulmonary secretions that are found in the respiratory tract. The clinical features of pertussis include 3 stages: the catarrhal, the paroxysmal, and the convalescent. The incubation period is approximately 7 to 10 days. The illness itself can last anywhere from 2 to 6 weeks, sometimes even longer. The classic whoop at the end of the cough can be actually absent in patients who have been vaccinated in the past. So we're not necessarily seeing the classic presentation of whooping cough, what people are used to hearing or what has always been described. In infants, the cough can actually even be absent. So in infants, we're just seeing episodes of apnea often. Unvaccinated or incompletely vaccinated infants under the age of 12 months are at the highest risk for life-threatening complications and death. So the stages of pertussis, the Ketterall lasts 7 to 10 days. Your patients experience coryza or cold-type symptoms, low-grade fever, mild cough, occasional cough. So it looks a lot like a regular viral upper respiratory infection. The paroxysmal phase is the phase that can last 1 to 6 weeks. Patients have paroxysms of rapid coughs, which is why it's called the paroxysmal phase. The high-pitched whoop at the end of the cough, like we said, which is often absent, they can have cyanosis. They can also have vomiting from the coughing. Convalescent, again, is lasting 7 to 10 days. So this is at the end, and this is a gradual recovery. The cough is lessening. It's not nearly as severe. However, during the convalescent phase, that paroxysmal coughing can return with any subsequent URI type infection. So patients can feel like they're getting better, then they're exposed to another virus, so they get another URI, and that paroxysm of coughing can return. The Tdap vaccine was first licensed for adolescents and adults in 2005. So we really haven't had a full 10 years of revaccinating adults against pertussis. We have 2 vaccines that are licensed. Boostrix, which is put out by GlaxoSmithKline. It's approved for 10 years of age and older. And then we have Adacel, which is put out by Sanofi Pasteur. This is approved only for the use in patients 11 to 64 years of age. Both vaccines are preservative-free. They found that we get a similar antibody response from a single dose of the Tdap vaccine as compared to 3 doses of the pediatric formulation. So we really should be getting a good boost if we can get our adults boosted against the Tdap illnesses. It is combined with tetanus toxoid and reduced amount of diphtheria toxoid. So before we were just doing a single TD, the tetanus and diphtheria toxoid for adults. They're still getting that protection from the Tdap vaccine, but we're adding the pertussis. At this point, the Tdap vaccine is approved for persons who have completed the childhood DTP or DTAP series. The ACIP recommends a single Tdap vaccine for ages 19 years and above, regardless of the interval since their last tetanus vaccine. So if you have a patient who got a plain TD 2 years ago, you're still going to immunize them with a Tdap vaccine. Pregnant women are now recommended to get a Tdap booster in the 3rd trimester of each pregnancy. This has changed. It was previously just during one pregnancy. Now, even if this patient had one last year with a pregnancy, if they're pregnant again, we're going to boost them again in the 3rd trimester of this pregnancy. At this point, we're recommending after the Tdap booster that we will go back to the plain TD for routine boosters every 10 years. The contraindications of the Tdap vaccine are severe allergic reaction to the vaccine components, encephalopathy not due to any other cause within 7 days of pertussis-containing vaccines. So if we have a patient who previously had an encephalopathy with no other known reason for causing it within a week of a pertussis vaccine in the past, they are not going to be getting Tdap boosters. Some of the precautions include Guillain-Barré syndrome within 6 weeks after a dose of tetanus in the past, a progressive neurologic disorder, severe local reaction, moderate or severe acute illness. Adverse reactions, local reactions, pain, swelling at the injection site range from 21 to 66%. Some people are getting temperatures above 100.4. That's only 1% of the population. So still rare. Moving on to varicella. Varicella illness is caused by Varicella Zoster virus. This is in the herpes virus group. Humans are the only source of infection with varicella. Varicella is highly infectious, highly contagious. It's transmitted by touching or breathing the aerosolized virus. It can be transmitted through the respiratory tract and the conjunctiva. 90% of cases occur before the age of 15. In the early 90s, we had 40 million cases of varicella disease every year, 10 to 13,000 hospitalizations, and 100 to 150 deaths annually. Varicella has a 10 to 21 day incubation period. You can have a prodromal fever and malaise. Fever can be around 102. Then you develop a pruritic rash. So they're getting an itchy rash. Starts with macules, then goes to papules, then goes to vesicles, and then to crusting. Patients can have 200 to 500 of these lesions on their bodies, and you get several crops of them over several days. So you'll have this rash in various stages of healing because it goes through the pattern of macules, papules, vesicles, and then crusting. Lesions occur on the head, chest, back, and extremities. Can also occur in the mucous membranes, so in the oral cavity, even in the vagina. Patients are contagious 1 to 2 days before the rash starts, and then up until the crusting occurs. After the acute infection, the virus stays latent in the sensory nerve ganglia. Reactivation of the latent infection causes herpes zoster. Varicella disease is more severe in adult patients than in children. Typically, they have more complications. Varicella vaccine is called Varivax. It's put out by Merck. It's a live attenuated viral vaccine. It is preservative-free. Was first licensed in the U.S. in 1995. It is approved for patients 12 months of age and older. In healthy individuals, after receiving 1 dose of the vaccine, 78% develop an antibody. 99% develop an antibody after 2 doses. The antibody persists at least a year in 97% of the patients. If patients get breakthrough disease, the disease is generally very mild and extremely unlikely to cause complications. So what constitutes varicella immunity? Any written documentation of the vaccine, so 2 doses of the vaccine, laboratory evidence of immunity or of acute disease. Anyone born in the U.S. before the year 1980 is considered immune. Healthcare provider documentation of the disease also is considered evidence of immunity. And a history of herpes zoster diagnosed by a healthcare provider. Then we know that they have had varicella illness at some point in their lives to develop herpes zoster. This is a picture of the varicella disease, typical lesions on the trunk. Herpes zoster, we have 500 to 1 million cases every year in the U.S. The lifetime risk of developing herpes zoster is at least 32%. Risk factors for developing zoster include increasing age, immunosuppression, and young age of varicella infection, and that is under the age of 18 months. Latent varicella zoster virus reactivates and causes recurrent disease. Herpes zoster clinical features include a vesicular eruption unilaterally, so on only one side of the body, consistent with the distribution of a sensory nerve. Most common sites are the trunk and the 5th cranial nerve. 2 to 4 days prior to the eruption, patients can have some pain and paresthesia, so some tingling sensation in the area where the outbreak is going to occur. Patients have very few systemic symptoms, so they're not getting fever, malaise, and those kind of symptoms typical of a primary varicella illness. Herpes zoster complications include post-herpetic neuralgia, so pain that persists in the area of involvement. This pain can last for months to years. Ocular nerve involvement is called herpes zoster ophthalmicus. This is considered an ophthalmologic emergency. It can cause severe chronic pain. It can also lead to vision loss. Typically, herpes zoster ophthalmicus is very easy to diagnose because of the history and the classic appearance of the lesions on exam. However, sometimes it can just present with a red eye, which can make it very difficult to diagnose. This is a picture of a typical herpes zoster on the trunk. You can see it's on the one side and it's in the nerve distribution. This is a picture of herpes zoster ophthalmicus. And this is very clearly representing just the unilateral involvement, does not cross the midline of the face. Herpes zoster vaccine is called Zostavax. It's put out by Merck. The initial trial of this vaccine included 38,000 adults between the ages of 60 to 80. They had no history of prior shingles infection. They were followed for 3 years. The vaccine group had 51% fewer zoster episodes than the placebo group. The highest efficacy was in the 60 to 69 age group. They had 64% less zoster episodes. The efficacy decreased with age. Once the patients were over 80 years of age, they only had an 18% decrease. After herpes zoster vaccination, you can still develop herpes zoster. However, the disease is less severe, and there's a 66% decrease in postherpetic neuralgia. Another study in patients aged 50 to 59 showed a reduction in herpes zoster by almost 70%. Now, how long does the efficacy last? We're not sure. Not yet. So what are the recommendations for herpes zoster vaccine? It is recommended that a single dose of herpes zoster vaccine be given in patients 60 years of age and older. You are to vaccinate regardless of prior history of herpes zoster infection. Chronic medical conditions do not preclude vaccination unless there is a contraindication or a precaution. So what are the contraindications? Severe allergic reaction to the vaccine or any of its components, pregnancy or a planned pregnancy within 4 weeks, or immunosuppression. And that includes leukemia, lymphoma, other neoplasm of the bone marrow, AIDS, clinical manifestations of HIV infection, high-dose corticosteroid therapy, or patients who are receiving human immune mediators or modulators. Herpes zoster vaccine precautions, moderate to severe acute illness, current treatment with an antiviral. And just to point out that recent blood product use is not a precaution to Zostavax vaccine. Herpes zoster vaccine adverse reactions, local reaction such as swelling, redness can occur. There is no increased risk of fever, no serious reactions identified during the drug study. Merck does warn of cases of asthma exacerbation, polymyalgia rheumatica, and cardiovascular events. However, the incidence of this is extremely, extremely rare. Moving on to pneumococcal disease. Pneumococcal disease is caused by Streptococcus pneumoniae. It was first isolated by Pasteur in 1881. In 1883, it was discovered that it was associated with pneumonia. However, until the gram stain was discovered in 1884, it was presumed to be the cause of most pneumonia. In 1911, the first efforts to develop a vaccine for streptococcal disease were getting underway. However, in the 1940s, when penicillin arose, the interest decreased. Not until 1977 was the first pneumococcal vaccine approved in the United States. What they found was that even though penicillin was around, there was a lot of resistance. And even if it was treated with penicillin, people still were dying from the infection. So vaccination did ultimately come to be for pneumococcal disease. The bacteria Streptococcus pneumoniae is typically lancet-shaped. It is gram-positive. It is anaerobic, and there are over 90 serotypes of this bacteria. However, the 10 most common serotypes cause greater than 60% of invasive disease. Pneumococcal disease in adults can cause pneumonia, bacteremia, and meningitis. Pneumonia is the most common. Pneumococcal disease usually occurs when there is a pre-existing pulmonary illness in the patient. Pneumococcal pneumonia typically has a very abrupt onset. There is fever, shaking chills, although typically it is one single rigor. Recurring shaking chills are seen less commonly. Typically, patients have pleuritic chest pain. They have productive cough of mucopurulent, rust-colored sputum is most typical. They also experience dyspnea, tachypnea, hypoxia, tachycardia. They can have malaise. They can have weakness. Nausea, vomiting, and headache are less frequent in pneumococcal pneumonia. Pneumococcal pneumonia causes 175,000 hospitalizations per year. Causes 36% of adult community-acquired pneumonia, 50% of hospital-acquired pneumonia. It is a common complication of influenza and has a fatality rate of 5 to 7%. Fatality rate is much higher in elderly patients. Pneumococcal pneumonia complications include empyema, which is an infection of the pleural space, pericarditis, endobronchial obstruction, atelectasis, and lung abscess. Pneumococcal bacteremia, there are about 50,000 cases annually. 25 to 30% of patients who have pneumococcal pneumonia will end up with a bacteremia. The fatality rate of bacteremia is 20%. It is up to as high as 60% in elderly populations. Pneumococcal meningitis is the cause of 13 to 19% of bacterial meningitis in this country. 3,000 to 6,000 cases annually. A quarter of these patients also have pneumonia. Fatality rate is as high as 30%. The symptoms are the same as other meningitis. So they have the headache, lethargy, vomiting, fever, nuchal rigidity, etc. Neurologic sequela after this meningitis is very common. There's an increased risk in patients with cochlear implants as well. Increased risk of invasive pneumococcal disease is seen in immunocompromised patients, asplenia, heart disease, pulmonary disease, liver disease, renal disease, cigarette smoking, and cerebrospinal fluid leaks. The pneumococcal vaccine is purified pneumococcal polysaccharide with 23 types. Greater than 80% of healthy adults who are immunized with the vaccine develop antibodies. We see a poorer response in older adults, those with chronic illness, immunodeficiency, and children less than 2 years. Antibodies persist for approximately 5 years. The vaccine recommendations are for adults 65 years and older, adults greater than 19 who are cigarette smokers and who have asthma, and patients greater than 2 years of age with chronic illness, asplenia, who are immunocompromised, HIV infection, environments or settings that put them at an increased risk, or cochlear implants. And when we're talking chronic illness, we're talking any cardiovascular illness, pulmonary illness, diabetes, alcoholism, cirrhosis, etc. Now, revaccination with the pneumococcal vaccine. So if they've gotten it once already, routine revaccination of immunocompetent patients is not recommended. It is recommended for persons greater than 2 years of age at the highest risk of infection. And a single revaccination dose greater than 5 years from the first dose is what is recommended. So we're revaccinating patients greater than 2 years of age with asplenia, immunosuppression, history of a transplant, renal failure, nephrotic syndrome, or patients who were vaccinated at an age before the age of 65. Contraindications and precautions to pneumococcal vaccine are severe allergic reaction to the vaccine or any of its components, moderate to severe acute illness. Adverse reactions include local reactions. 30 to 50% of patients will get some sort of local reaction, such as swelling, erythema, typically lasts less than 48 hours. Fevers and myalgias occur in less than 1% of the population, and severe adverse reactions are rare. The goal for vaccine coverage of pneumococcal vaccine is greater than 90% of patients over the age of 65 years. Right now, only about 64% are vaccinated, so we're not doing a very good job here. We are doing an even poorer job in patients 18 to 64 with a chronic illness. Looking at a missed opportunity, greater than 65% of patients hospitalized with severe pneumococcal disease have been admitted to the hospital previously in the past 3 to 5 years. So we could vaccinate these patients at hospital discharge. We also recommend screening at clinician or pharmacy visits. Pneumococcal vaccine can be administered right along with the flu vaccine as well as the Zoster vaccine. So we can get our adults immunized against Zoster, pneumococcus, and flu all at the same time. Touch quickly are the hepatitis vaccines. Hepatitis A is an acute viral hepatitis. Humans are the only natural reservoir. In the pre-vaccine era, hepatitis A caused 100 deaths every year. 11 to 22% of patients with hepatitis A will require hospitalization. And in 1989, the annual cost of hepatitis A in the U.S. was $200 million. So what are the risk factors? Personal contact with an infected person, international travel, injection drug use, and men who have sex with men. Clinical features of hepatitis A are indistinguishable from other forms of hepatitis. You get an abrupt onset of symptoms, anorexia, nausea, abdominal pain, dark urine, jaundice. It is transmitted through the fecal-oral route. Usually does not last longer than 2 months, but viral shedding can last for 1 to 3 weeks. There are 2 hepatitis A vaccines out there. One is Havrix and one is Vacta. The schedule is 0, 6, and 12 or 18 months, depending on which vaccine you're using. Contraindications and precautions are severe allergic reaction to the vaccine, moderate to severe acute illness. Local reactions are the most common adverse event. Systemic reactions are uncommon, and there are no serious adverse reactions reported with the hepatitis A vaccine. Hepatitis B is a small double-shelled virus. It has numerous antigenic components. There's the core antigen, there's a surface antigen. Humans are the only known hosts. Hepatitis B can actually maintain its infectivity for up to 7 days at room temperature on surfaces. So that is significant. There are greater than 350 billion people chronically infected worldwide. It can cause chronic hepatitis and cirrhosis, causes up to 80% of hepatocellular carcinomas. So that's significant as well. The contraindications and precautions are similar to other vaccines. Severe allergic reaction to the vaccine or its components, moderate to severe illness. The schedule for the vaccine is 0, 2, and 6 months. And there are 2 vaccines licensed for adult, Recombavax HB and Energix B. Hepatitis B vaccine adverse reactions include pain at the injection site. There are mild systemic complaints in 11 to 17% of patients receiving the vaccine. So some myalgias, etc. Fever is rare, less than 1%, and systemic severe systemic reactions are also rare. I just want to touch on influenza for a second. We could do a whole presentation on influenza and influenza vaccination. But we all know influenza is a highly infectious viral illness. There are 3 types. Type A, which causes moderate to severe illness, and that affects all age groups. Type B is a milder form, and it typically occurs more often in children. Type C is rare in humans. We see changes in influenza, 2 types. The antigenic shift is a major change. That is caused by a new subtype, and it really raises the risk of a pandemic significantly. An antigenic drift is a minor change and can cause an epidemic, not a pandemic, more likely to cause an epidemic. So we all know that everyone should be getting an influenza vaccine annually. This year has been particularly harsh with influenza illness, and it just serves as a good reminder that we all should be getting immunized against influenza, and we should be recommending it for all of our patients. Now, some common misconceptions about vaccines. One of the primary ones is the overloaded immune system concept. And that is where if we try and immunize against too many illnesses at one time, the immune system would be overloaded and can't respond. If you look at the common cold, when someone is infected with the common cold, they are exposed to 4 to 10 different antigens within that cold. So if our immune system can handle that, it can handle multiple vaccines. Another example is a strep infection. So if someone has a strep throat, they are exposed to 25 to 50 different antigens. So if our immune system can handle a case of strep throat and respond to that, it can handle vaccinations. Another common misconception about vaccines is that illnesses that we vaccinate against are disappearing. They have disappeared. And although some vaccines have been decreased worldwide, such as polio, they have not been eradicated. And if we do not continue to immunize our population, unimmunized travelers who go to places where polio, measles are still common or still infecting the population, those unimmunized travelers bring them back and will reinfect our area or infect those patients who haven't been immunized. So there really are no diseases that have disappeared from our country that we still should not be vaccinating against. Another misconception is that more vaccinated than unvaccinated people get sick. Now, no vaccine is 100% effective. So if you take, for example, a school with 100 kids in it, and 5 of those have not been vaccinated against measles, per se, and there is a measles outbreak, all 5 of those unimmunized kids will be infected. Now, and maybe another 2 or 3 immunized kids will also be infected with measles. Why does that happen? Because no vaccine is 100% efficacious, and some people may not have responded to their initial vaccine. But in this case, more people, in fact, 100% of the people who were not immunized got sick, got the illness. And although some vaccinated people can still get sick, it is not 100% of the population of vaccinated people who will get sick. Another argument is that hygiene and nutrition are responsible for the reduction in disease rates. Although it is true that socioeconomic conditions have improved and have really greatly reduced the disease transmission in our country, the greatest decrease in illnesses actually have coincided with the introduction of vaccines. For example, in 1963, when the measles vaccine was introduced, that showed the greatest decrease in measles incident, not necessarily hygiene or sanitation changes. And the last misconception that I just want to address is that natural immunity is better than vaccine-acquired immunity. It is true that natural immunity does last longer than some vaccines. However, natural immunity comes with infection of the illness. So you are still at risk for complications from the natural infection. So for example, let's look at measles. So for measles, the risk of encephalopathy with measles infection is 1 in 1,000. With the measles vaccine, the risk of encephalopathy is 1 in 1,000,000. So although it is true that you will get immunity from natural infection, you also are increasing your risk of complications. And so that is not, in my eyes, a better way to acquire immunity. So hopefully we can address these misconceptions with our patients and convince them that vaccination is a good thing. So in summary, vaccines have been the most influential development in public health. Despite this, we are doing a very, very poor job with our adult patients. We're doing a great job with kids. We are not doing very well with adults. So we as healthcare providers need to work at increasing those rates. We need to look at it at every visit, at every opportunity we have to vaccinate our adults. And hopefully we're able to dispel some common misconceptions regarding vaccinations that will help make our patients more accepting and more interested in becoming vaccinated, especially as adults.